In this video, we'll be seeing about the intracellular accumulations. Okay, intracellular accumulations are due to 4 reasons. Okay, let's see about those 4 reasons. They may be due to inadequate removal of a normal substance. Say for example, you have a normal substance that has to be removed. If it is not removed, and or else if it is not removed in adequate amount, because of the defects in several mechanisms, maybe the defect lies in packaging or transport, so something like that. If suppose inadequate removal of a normal substance because of the defects in the packaging and transport, um, then intracellular accumulations occur. Okay, for example, fatty change statuses in liver occurs. And another reason is abnormal endogenous substance may get accumulated. Why the endogenous substance may get accumulated? Because of the genetic or acquired defects. Because of the genetic or acquired defects, abnormal endogenous substance gets accumulated. So why genetic or acquired defects occurs? Because there may be a defect in packaging, transport, secretion. Okay, genetic or acquired defects are nothing but defects in packaging, transport, or secretion. Genetic or acquired defects occur because of the mutated forms of alpha 1 antitrypsin. Okay, so due to the genetic or acquired defects in packaging and transport, endogenous substance, abnormal endogenous substance, not normal substance, abnormal endogenous substance. Endogenous substance nothing but substance which lies within a cell. So, if there is inadequate removal of some normal substance or abnormal endogenous substance getting accumulated because of genetic or acquired defects, then intracellular accumulation occur. Not only this, but also due to the suppose you have some metabolite, but that metabolite has to be degraded. If it is not degrading, so failure of degradation of metabolite because of an enzyme deficiency. So in a, in all types of metabolism, the carbohydrate, protein, and everything, we have enzymes, inherited enzymes. So if there is deficiency of those inherited enzymes, then metabolite is not dehydrated. So there will be failure of degradation of metabolite. So if such failure occurs, then storage diseases occur. Okay, and this is the third reason. Fourth one is if there occurs deposition accumulation of an abnormal, you have something called like abnormal exogenous substance. If such abnormal exogenous substance gets deposited or if it gets accumulated, then the cell has neither, okay, it will not have enzymatic machinery to degrade that substance. Okay, uh, if suppose abnormal exogenous substance gets deposited or accumulated, the body or the cell should have some machinery to either degrade it or to transport it. If the body lacks such machinery, then accumulation of particles happen. For example, carbon or silica particles get accumulated. This is a type of alteration. We will be studying in further lessons in pathology. If these type of overload, if it is controlled, then we'll be saying those accumulation is reversible accumulations. In inherited storage diseases, suppose we will have storage diseases like glycogen storage disease, lysosomal storage disease. In those inherited storage diseases, the accumulation is progressive, which means it is keep on increasing, and the overload it may cause cellular injury. Okay, totally there are 4 reasons: inadequate removal of normal substance, an accumulation of abnormal endogenous substance due to genetic or acquired defects, and failure to degrade. Will be not able to degrade metabolites because of the inherited enzyme deficiencies and the portion accumulation of abnormal exogenous substance. Also, not only endogenous substance, abnormal endogenous substance because of genetic or acquired defects, but also abnormal exogenous substance because of the failure of degradation of the substance or the transport from one place to another. These are the 4 reasons. Now let's go to lipids. Suppose all major classes of lipids will be accumulating in cells. Okay, what are the major classes of lipids? Triglycerides, cholesterol esters, uh, cholesterol esters, and phospholipids. Phospholipids are composed of myelin figures. Usually, in case of necrotic cells, phospholipids are definitely myelin figures are found in necrotic cells, those cells which are undergoing necrosis. So in those myelin figures, the major component is phospholipids. Okay, so now we'll be focusing mainly on triglycerides and cholesterol esters getting accumulated. Abnormal complex of lipids and carbohydrates also they'll be accumulating. In case of lysosomal storage disorders, abnormal complexes of both lipids and carbohydrates get accumulated in case of lysosomal storage disease. Okay, but usually triglycerides and cholesterol or cholesterol esters get accumulated. Suppose if you see in case of necrotic cells, if you see myelin figures, phospholipids or the components. Okay, now let us study about steatosis or fatty change. What is steatosis? Steatosis is nothing but otherwise we'll be saying it as fatty change. It is nothing but abnormal accumulation of triglycerides. If that triglyceride gets accumulated abnormally inside the parenchymal cells, okay, that is called steatosis. This change is often you'll be seeing in liver because it is a major organ. Since liver is involved in fat metabolism, often you'll be seeing these kind of changes in liver, but it can also occur in heart, muscle and kidney. So let us see what is the cause of the steatosis. Why abnormal accumulation of triglycerides within the parenchymal cells happen? Because of toxins, because of malnutrition. Protein malnutrition, nothing but daily intake of protein should be up to some amount. If it's not taken normally, then steatosis occur. Then suppose if you are in inhaling toxins or if you're including toxins in your food, steatosis happens, due to which accumulation of triglycerides happen. Diabetes mellitus is nothing but a dangerous condition which affects fat metabolism, so due to which accumulation of triglycerides happen in liver. Okay, so it may be due to diabetes mellitus and obesity. Okay, obesity is also one of the cause due to which liver gets affected, so that due to that accumulation of triglycerides also happen. Anoxia means lack of no oxygen at all. If body is getting no oxygen, then steatosis occur. Abnormal accumulation of triglycerides happen. Okay, in case of developed nations like US, usually this fatty change in liver occurs because of alcohol abuse and non-alcoholic fatty liver disease. It will be often associated with diabetes and obesity. Alcohol abuse and non-alcoholic fatty liver disease, often it will be associated with diabetes and obesity. Okay, now let's see how cholesterol and cholesterol esters get accumulated. Okay, usually we have cellular metabolism of cholesterol, and that is tightly regulated only for to make up the cell membrane, not for intracellular accumulations. So the cellular metabolism of cholesterol, it is regulated only to make up cell membrane. Okay, it is not regulated to accumulate inside the cell. Okay, accumulations usually in case such accumulation occur, it will be appearing as intracellular vacuoles. Okay, so now let us see 4 cases where cholesterol or cholesterol esters accumulate. Just remember a mnemonic: AXCON, which means AX is for atherosclerosis and xanthomas. CON is for cholesterolosis and Niemann-Pick diseases type C. Okay, atherosclerosis, xanthomas, cholesterolosis, Niemann-Pick disease. Now let's see about atherosclerosis. So in case of atherosclerotic plaques, we have smooth muscles, and we also have macrophages in the intima layer. So totally there are three layers in case of arteries, namely intima, media and externa. Okay, out of these layers, in intima layer we have muscles, smooth muscle cells and macrophages. Okay, let us take aorta and large arteries. Okay, suppose if those smooth muscle cells, macrophages are getting filled with lipid vacuoles. Okay, and most of which are made up of cholesterol and cholesterol esters. Okay, such plaques are called atherosclerotic plaques. Okay, smooth muscles and macrophages in the intima layer are filled with lipid vacuoles, and most of which are cholesterol and cholesterol esters. Okay, such plaques are called atherosclerotic plaques. So such cells, it be having foamy appearance, and suppose those foam cells, if aggregated in the intima, it will be producing yellow cholesterol laden atheromers. So if foam cells, those lipid vesicles get a foamy appearance. So those foam cells, suppose if it gets aggregated, it produces a yellow cholesterol laden atheromers characteristic in the intima. Okay. So yellow cholesterol laden atheromers characteristic is seen in which disorder? Atherosclerosis. Okay. So those fat laden cells, some of those foam cells, it get ruptured. Okay. Suppose if it get ruptured, it will be releasing lipids into extracellular space because it is intracellular lipid vesicles only, no. So it is releasing lipids into extracellular space when it is getting ruptured. So the mechanism of cholesterol accumulation in atherosclerosis that you'll be studying detail in further chapters in patho. The extracellular cholesterol esters, it will be crystallizing. So when the intracellular vesicles get ruptured, those vesicles will be releasing lipids into extracellular space. So consequently, the extracellular cholesterol esters which are released, it will be crystallized. So how it will be crystallized? It will be crystallized either in the shape of long needles producing quite distinctive clefts. So in case of tissues in the tissue sections of atherosclerotic patients, you will be seeing the crystallization of cholesterol esters in the shape of long needles. Okay, long needles which are quite visible as distinctive clefts. Okay, long needles, distinctive clefts, which are made up of cholesterol esters in tissue sections. Such patients are suffering from atherosclerosis. Okay. Next, let's move to xanthoma. Xanthoma is nothing but intracellular accumulation of cholesterol within macrophages. So we have at intima we have macrophages. Suppose if cholesterol gets accumulated within macrophages. Atherosclerosis is nothing but mainly made up of cholesterol and cholesterol esters, mainly cholesterol esters. But in xanthoma, mostly cholesterol gets accumulated within macrophages. This is also characteristic of acquired and hereditary hyper. Suppose acquired and hereditary is nothing but through heredity, body may have high content of lipid. So in case of hyperlipidemic states, macrophages are seen with high level of cholesterol. Okay, and mostly there are different types of hyperlipidemia, hereditary type 1 hyperlipidemia, type 2, and all those things. Okay, in all those states we'll be seeing cholesterol within the macrophages at intimal layer, and especially this condition is called xanthoma. Clusters of foamy cells are found in subepithelial connective tissue. Okay, where we'll be seeing these foamy cells, nothing but accumulation of cholesterol in the subepithelial connective tissue, especially in organs like skin and in tendons. And what does it produce? It produces tumorous masses, and those tumorous masses, so the foamy cells which are accumulated in the subepithelial connective tissue, especially in case of skin and tendons, in the condition called xanthoma, where acquired and hereditary hyperlipidemic states are found, produces tumorous masses known as xanthomas. Those tumorous masses will be saying it is xanthomas. Okay. Next, let's move on to cholesterolosis. Okay, this is nothing but focal accumulations. Okay, we have cholesterol laden macrophages. At macrophages, suppose if cholesterol is getting accumulated, it will be appearing as foam cells. So, if there is focal accumulation of cholesterol laden macrophages, especially in the lamina propria. Suppose in macrophages, if it getting accumulated, either it will be atherosclerosis or xanthoma. Okay. Suppose if it is getting accumulated in lamina propria of the gallbladder, we'll be saying it as cholesterolosis. Okay. The mechanism of accumulation of those cholesterol in macrophages and in lamina propria of the gallbladder is still unknown. We don't know how it is getting accumulated. Nine-month practices. Now let's go to the fourth one. Nine-month practices type C. It is a lysosomal storage disease. How it is caused? It is caused by mutations. Okay. Those mutations are seen especially in enzyme. We have cholesterol trafficking. Okay. In the process of cholesterol trafficking, some of the enzymes are involved. So if there occurs a mutation in enzymes involved in cholesterol trafficking, it will result in cholesterol accumulation in multiple organs. So 9-month practice. PIC disease, nothing but lysosomal storage disorder, which is caused by mutations affecting an enzyme involved in cholesterol trafficking, and because of the because of the damage of that, because of the enzyme getting affected, it will result in cholesterol accumulations in multiple organs. Okay, so this is called Niemann practices. So axon, atherosclerosis, xanthoma, cholesterolosis, Niemann practices. This is what. Next, let's move on to proteins. Proteins, nothing but intracellular accumulations of proteins. Usually it will be appearing as rounded eosinophilic droplets, vacuoles, or aggregates in the cytoplasm. Okay, so inside the cell, suppose if you see something rounded, or if you see something eosinophilic, or droplets of vacuoles, if you see aggregates in the cytoplasm, rounded eosinophilic droplets, vacuoles, if you see such aggregates in the cytoplasm into the cell, we should definitely find it as protein. By electron microscopy, if you see through electron microscopy, they may be amorphous, they may be fibrillar, or maybe crystalline. So by naked eye it will be appearing as rounded eosinophilic droplets, vacuoles, but by electron microscopy it will be like amorphous, fibrillar, or crystalline. Amorphous, fibrillar, or crystalline. Okay, in appearance, just remember like AFC, just like KFC, it is AFC, amorphous, fibrillar, or crystalline. Okay, in some disorders, such as, we have amyloidosis. Amyloidosis means abnormal proteins deposit primarily in extracellular spaces. In extracellular spaces, if abnormal proteins gets deposited primarily, we'll be saying this as amyloidosis. Excess of proteins, we have cells. If excess of proteins within the cells sufficient to cause morphologically visible accumulations have diverse causes. Okay, morphologically, if excess of proteins within the cells is getting accumulated, it has several causes. Namely, we have totally 4 or 5 causes. First let me list out. It may be due to reabsorption droplets in proximal renal tubules. We have proximal renal tubules. So protein may get accumulated inside the cell, maybe due to reabsorption droplets in proximal renal tubules, or maybe due to Russell bodies, or maybe due to defective intracellular transport and secretion of critical proteins. Defective intracellular transport and secretion of critical proteins. Okay, if there is any defect in either intracellular transport, or if there is a defect in secretion of critical proteins, and if there is an accumulation of cytoskeletal proteins, or if there is aggregation of abnormal proteins also. So these are the 5 causes. Reabsorption droplets in proximal renal tubules may be due to resolved bodies, if there is defective intracellular transport and secretion of critical proteins, if there is accumulation of cytoskeletal proteins, if there is aggregation of abnormal proteins also. Okay, reabsorption droplets in proximal renal tubules, especially this reabsorption droplets in proximal renal tubules occurs in renal diseases. Okay, in case of renal diseases, usually protein will be lost in the urine, and that will be denoting as proteinuria. In the kidney, small amounts of protein filtered through, usually in kidney small amounts of protein it will be filtered through glomerulus and normally reabsorbed, and not only filtration happens in kidney but also in proximal tubule penocytosis happens. So by the process of penocytosis, again the protein gets reabsorbed into the body, so the protein will not be excreted in a normal person. In disorders, for example, in disorders with heavy protein leakage across the glomerular filter, there is increased reabsorption of protein. So at the glomerulus some vesicles will be there, so the increased reabsorption of protein, usually proteins uh, proteins will be filtered through glomerulus, it will be sent to proximal tubule, and by penocytosis it gets normally reabsorbed. If it is not done like this, then in heavy protein leakage across the glomerular filter, there is increased reabsorption of protein into vesicles, so the proteins get reabsorbed into the vesicles, so the protein appears as pink hyaline droplets within the so in tubular cell, suppose in tubular cell, okay, in tubular cell histology section, if you are seeing pink hyaline droplets within the cytoplasm of the tubular cell, pink hyaline droplets, if you see, then definitely there is there is proteinuria, which means reabsorption droplets in proximal renal tubules. um, So usually reabsorption droplets in proximal renal tubules, it is usually seen as hyaline droplets in case of proteinuria, especially in renal disease. Normally it has to be filtered through glomerulus, and by panocytosis it has to be reabsorbed. Suppose if it is not reabsorbed and if they are seen as droplets in proximal renal tubules, definitely the condition is called proteinuria. So this is a concept involved here. This appearance of reabsorption droplets in proximal renal tubules, or the protein getting the protein getting reabsorbed in the vesicles in the tubular cell. And when you are seeing the section of tubular cell, you'll be seeing pink hyaline droplets, and all of these processes are reversible. If the proteinuria it is diminishing, okay, the loss of protein through urine, if it is diminishing, definitely these processes are irreversible. Of course those protein will not be getting accumulated in the vesicles, it will be not seen as hyaline droplets in the histology section. So this process is reversible when the protein it is not excreting through urine. The protein droplets, if it is metabolized and disappeared by filtration through glomerulus and absorption through pinocytes in proximal tubule, definitely this process is reversible. Okay, this is the first reason for the excess of proteins which is causing cellular injury. Okay, the second reason is because of Russell bodies. Okay, usually certain plasma cells it will be engaged in producing immunoglobulins. Okay, so uh, in case of certain plasma cells which are involved in immunoglobulins, those proteins may get secreted more, but those proteins are normal. But though those proteins are normal, they may be secreted more. So because of the abnormal amount of secretion of normal proteins, which is nothing but otherwise we say it is excessive amount of production of normal proteins. You know, this occurs. Okay, so in this condition, endoplasmic reticulum it will be becoming hugely distended. Okay, endoplasmic reticulum is hugely distended, and it produces large homogeneous eosinophilic inclusions called Russell bodies. So in case of certain plasma cells which are involved in the synthesis of immunoglobulins, if proteins are secreted normal proteins, if it is secreted excessive amounts, endoplasmic reticulum gets hugely distended, it will produce large homogeneous eosinophilic inclusions, and those large homogeneous eosinophilic inclusions are called Russell bodies. Okay, defective, and another third reason is defective intracellular transport and secretion of critical proteins. We have intracellular transport and secretion of critical proteins. So if there is defect in the intracellular transport and in the secretion of critical proteins, then definitely proteins get accumulated. So in which condition get accumulated? In case of alpha 1 antitrypsin deficiency, mutations in proteins significantly slow folding. Okay, alpha 1 antitrypsin deficiency leads to slow folding of proteins, because there is mutation in protein when alpha 1 antitrypsin is deficient. So because of this, partially folded, so slow folding is nothing but it may relate to partially folded intermediates. So partially folded intermediates get accumulated, which aggregate in the, especially in case of liver, endoplasmic reticulum is there. So in the endoplasmic reticulum of liver, it will be aggregated, but it will not secreted. So after aggregation, it has to be secreted, no? So because of the alpha 1 antitrypsin, it will be not. Alpha 1 antitrypsin deficiency, it will be not secreted. The resultant deficiency of the so if that enzyme is deficient, then it will cause emphysema. Okay, in many of these diseases, the pathology results not only from loss of protein function, but also we have loss of protein function. Okay, because there is a mutation in the protein because of the alpha 1 antitrypsin deficiency. Not only the loss of protein function, but also the endoplasmic reticulum stress caused by the, we have misfolded proteins. So loss of protein function, but also because of the misfolded proteins, the endoplasmic reticulum is under stress. So when the endoplasmic reticulum is under the stress, then definitely there will be apoptosis of the cells. Okay, yes. Third reason is it is due to defective intracellular transport and secretion of critical protein because of alpha-1 antitrypsin deficiency. Endoplasmic reticulum is under stress and thus the cell undergoes apoptosis. It may also, because of the alpha-1 antitrypsin deficiency, it will also cause slow folding proteins or partially folded intermediates, and thus it will be causing emphysema also. So let's go to accumulation of cytoskeletal proteins. There are several types of cytoskeletal proteins. Is, of course, we know microtubules, which is usually 20 to 25 nanometer in diameter, and we also have thin actin filaments, 6 to 8 nanometer. Usually microtubules are generally from 20 to 25 nanometer in diameter, which is very high comparing to thin actin filaments, which is just 68 nanometer. And we also have thick myosin filaments, which is higher than actin filaments, whose diameter is higher than actin filaments, but lesser than microtubules. So microtubules have the highest diameter, and next to that we have myosin, and the least is actin filaments. Okay, intermediate filaments are nothing but 10 nanometer, which are little bit lesser than myosin filaments. Intermediate filaments which will be providing flexible intracellular scaffold that organizes a cytoplasm. Okay, we have cytoplasm. Okay, we have to organize a cytoplasm, and so that it should be, it should be flexible enough to allow allow intermediates to pass through. Okay, so that is done by intermediate filaments, which is about 10 nanometer in diameter, and it also resists force applied we have lot of force to the cell. Okay, water, it may be due to the pressure, osmotic pressure or something else. So to resist those force we need some flexibility, so it is provided by intermediate filaments, which is about 10 nanometer in diameter. So they are divided into those intermediate filaments which are providing flexibility. They are divided into five classes. Keratin filaments, characteristic of epithelial cells. Okay, we have epithelial cells. So the characteristic of epithelial cells is mainly contributed by keratin filaments. Then next we have neurofilaments. Okay, it is for neurons. Next we have desmin filaments. It is for muscle cells. Next we have vimentin. It is vimentin filaments, which is for connective tissue cells. So we have keratin filaments, which is characteristic of epithelial cells, neurofilaments, neurons, and desmin filaments. It is for muscle cells. Vimentin, it is for connective tissue cells, and glial filaments, it is for astrocytes, which is a cell in CNS. Okay, central nervous system. So glial filaments, vimentin filaments, desmin filaments for muscle filaments, neurofilaments, keratin filaments. Okay, all these things. Like accumulation of let's say there occurs accumulation of keratin filaments, which is nothing but a characteristic of epithelium. In epithelium, if suppose the accumulation of keratin filaments and neurofilaments nothing but neurons. If such accumulation occur, they will be associated with certain type of cell injury. Okay, alcoholic hyaline is nothing but a eosinophilic cytoplasmic inclusion in liver. We have eosinophilic cytoplasmic inclusion in case of liver cells. Okay, in case of alcoholic liver disease, alcoholic hyaline is nothing but an eosinophilic cytoplasmic inclusion, and it is composed predominantly of, we have keratin intermediate filaments. Okay, so those alcoholic hyaline, which is an eosinophilic cytoplasmic inclusion in case of alcoholic liver disease, consist mainly of keratin intermediate filaments. Next, neurofibrillary tangle. It is found in the brain in case of Alzheimer's disease. We have Alzheimer's disease. Okay, in Alzheimer's disease in the brain, we'll have neurofibrillary tangle. Neurofibrillary tangle. Mainly it will be containing neurofilaments and other proteins. So Alzheimer's disease nothing but is due to the intracellular accumulation of the proteins, especially neurofibrillary triangle. It is found in Alzheimer's disease, which is containing neurofilaments and other proteins. Next, another reason is it may be due to aggregation of abnormal proteins. Abnormal proteins means abnormal or misfolded proteins may deposit in tissues and of course they will be interfering with normal functions. So those deposits, it can be intracellular or extracellular or both, and the aggregates may either directly or indirectly it will be causing pathologic changes. So if those deposits which occur either inside the cell or outside the cell or both, it will be either directly or indirectly it will be causing pathologic changes. So if those so example for the aggregation of abnormal proteins is amyloidosis. Okay, certain forms of amyloidosis are nothing but the example of the aggregation of abnormal proteins either inside the cell or outside the cell. It will be interfering with the normal function of the cell. Okay, these disorders are sometimes called proteinopathies. So those disorders, okay, which are actually causing amyloidosis, okay, they are called what sometimes called proteinopathies or protein aggregation diseases. These are accumulating proteinopathies or protein aggregation diseases. Okay, next, these are the 5 reasons: reabsorption droplets in proximal renal tubules. Okay, it should be absorbed pinocytosis if it is not occurring, especially in case of proteinuria, and it appears as pink island droplets in the cytoplasm of the tubular cell. The second one is Rosal bodies. Rosal bodies nothing but normal secreted proteins. If it is getting accumulated in endoplasmic reticulum, it will be hugely distended and produce large homogeneous eosinophilic inclusion. Those bodies are Rosal bodies. And defective intracellular transport. Okay, intracellular transmission and secretion of critical proteins nothing but because of alpha 1 antitrypsin deficiency. There occurs accumulation of partially folded intermediates in the endoplasmic reticulum of the liver are not secreted, and emphysema may also occur. Thereby endoplasmic reticulum will be under stress and apoptosis of the cells occurs. So defective intracellular transport, secretion of critical proteins may be one of the reasons, and accumulation of cytoskeletal proteins because of the keratin filaments. Okay, keratin intermediate filaments. Alcoholic liver disease occurs in gauge cell injury, and neurofibrillary tangle Alzheimer disease occurs. The aggregation of abnormal proteins, example or amyloidosis, where abnormal or misfolded proteins it may get deposited in tissue and interfere with normal function. So there are 5: reabsorption droplets proximal renal tubules, Rosal bodies, defective intracellular transmission, secretion of critical proteins, accumulation of cytoskeletal proteins, aggregation of abnormal proteins. Okay, next let us go to hyaline change. The term hyaline usually it will be referring it refers to an alteration in the cells. Within the cells, if there occurs alteration or in the extracellular space. Okay, so if there occurs alteration within the cells or an extracellular space, it will be giving homogeneous glassy pink appearance in the routine histological section. So in the routine histological section nothing but which will be stained with amatoxylin eosin. So if there occurs alteration in a cells or extracellular space, there occurs homogeneous glassy pink appearance. So the homogeneous glassy pink appearance is due to so those homogeneous glassy pink appearance will be termed as hyaline. Okay, usually it is used as descriptive histological term rather than it is not a specific marker for cell injury. It is a histological term. It is not a specific marker for cell injury. This morphological change it is actually produced by variety of alterations. Yes, of course it is due to hyaline change. It is due to alterations, not due to cell injury or something. It is not a specific marker for cell injury also. It is not a specific pattern of accumulation. Okay, intracellular accumulations of amyloidosis or etc occurs due to the accumulation of certain particles, but hyaline change is not due to accumulation. It is definitely due to alteration. Okay, it does not follow a specific pattern of accumulation. Intracellular accumulation of protein described earlier are examples of intracellular hyaline reabsorb okay, intracellular accumulation of proteins. For example, we have discussed about alcoholic hyaline and reabsorption droplets, Rosal bodies. No, all those things are examples of intracellular hyaline deposits. Okay, hyaline deposits. So next, let's see some examples for extracellular hyaline. This has been more difficult, and actually it is extracellular hyaline. It is more difficult to analyze itself. Collagenous fibers in old scars. Let us see some of the old scars. In old scars, if collagenous fibrous tissue appears and if it is getting hyalinized. So if in old discuss if collagenous fibrous tissue appears and if it is hyalinized, but the biochemical basis, so we don't know what is the biochemical reason for the change. In old discuss the collagenous fibrous tissue gets hyalinized, but we don't know the biochemical changes of the changes of the uh, changes of the hyalinization of the collagenous fibrous tissue. So those type of changes or example for those type of hyalinization in collagenous taking place in collagenous fibrous tissue, example of extracellular hyaline. Okay, in case of long standing hypertension, we have long standing hypertension. We also have diabetes mellitus. Okay, in those type of hypertension, diabetes mellitus, we have walls of arterioles, especially in kidney. In kidney, we have renal artery. So in the wall of arterioles in kidney, it gets hyalinized in case of hypertension or diabetes mellitus. Why? Because of extravasated plasma protein deposition. Okay, plasma protein and basement membrane material gets deposited. So because of the extravasated plasma protein and the basement membrane material, because of the deposition of basement membrane material and plasma protein, those arterioles of the kidney gets hyalinized in case of long-standing hypertension and diabetes mellitus, which is an example for hyaline change. Not only this is an example for extracellular, but also collagenous colonization of collagenous fibrous tissue where the biochemical change is not known, is an example for extracellular hyaline. For intracellular hyaline, as reabsorption droplets, result bodies, alcoholic hyaline, though all those protein accumulations are example for intracellular hyaline, where alteration of cells occur, not the accumulation. Okay, glycogen. Next, let's move to glycogen. Actually, glycogen is readily available energy source. Okay, it is stored in the we have healthy cells in the cytoplasm of healthy cells. The readily available energy source which is stored is glycogen. Okay, in excess amount, if those glycogen gets deposited inside the cell, then those patients are diagnosed with abnormality in either glucose or glycogen metabolism. Okay, either glucose or glycogen metabolism, there is an abnormality in those patients when it is deposited in excess. Whatever the clinical setting, glycogen masses appear as clear vacuoles. Okay, whatever it may be. In normal people, usually glycogen mass, it will be appearing as clear vacuoles within the cytoplasm. Glycogen to be dissolved in aqueous fixators. So if you want to identify glycogen, mostly it is readily identified when those tissues with glycogen which appear as clear vacuoles in the cytoplasm should be fixed in absolute alcohol, so that it will be very easy to identify. Okay, staining. Suppose if you are staining those tissues which has glycogen clear vacuoles in cytoplasm with best-carmine or the PAS reaction. Best-carmine or PAS reaction, it will be imparting a rose to violet color to the glycogen. So in those conditions where it is stained with best-carmine or PAS reaction, it will be like rose to violet color to the rose to violet color. And diastase digestion of the parallel section. So um okay, and not only this, when it is stained with best-carmine pass reaction, not only the impartition of rose to violet color to the glycogen occurs, but also diastase digestion of the same parallel section occurs. Okay, there occurs digestion. Okay, before staining it to rose to violet color, there occurs digestion of a parallel section. So there occurs hydrolyzation also. Hydrolyzation of the glycogen also occurs when we are staining with best-carmine pass reaction, and then impartition of rose to violet color happens. So why rose to violet color impartition happens when the glycogen it is stained with best-carmine pass reaction, means it is due to the hydrolyzation. Okay, before staining, hydrolyzation occurs. Diabetes mellitus, actually it is a prime example of the disorder of glucose metabolism that we know. In this disease, glycogen, it is found in renal tubular epithelial cells. Yes, of course. Glycogen is found in renal tubular epithelial cells, as not only in renal tubules but also within the liver cells and B cells of islets of Langerhans and heart muscle cells. Renal tubular cells, epithelial cells, and within the liver cells and with the beta cells of islets of pancreas, heart muscle cells. So all these cells are affected. That's why glycogen gets accumulated in case of diabetes mellitus. Glycogen accumulates within the cells in a group of related genetic disorders. Okay, in group of related genetic disorders, if glycogen get accumulated, collectively we will be referring it as what? Glycogen storage disease or glycogenosis. In these diseases, enzymatic defects in the synthesis or breakdown of glycogen results in, suppose, in the synthesis or in the breakdown of glycogen, if any enzyme is deficient, if there is any defect in the enzyme, then there occurs massive accumulation of the glycogen, and absolutely it causes cell injury and cell death. Why there is cell injury and cell death in case of glycogen storage disease, glycogenosis? Because of the uh, because of the defects in either synthesis or breakdown of glycogen. Okay, Massive accumulation also occurs. What about the pigments? Pigments are nothing but they are colored substances, some of which are normal constituents of cells. Okay, example melanin. Okay, actually pigments are nothing but colored substance, but some of those pigments are nothing but normal constituent cells only. For example, melanin, it is normal constituent, but it is but the color is different, whereas others are abnormal. Some pigments will be abnormal, but it accumulate in cells under special circumstances. Other pigments get accumulated, and we will be saying it as abnormal accumulation of pigments. Okay, pigments, it can be exogenous, coming from outside the body, or maybe endogenous. It can be synthesized within the cells itself. Within the cells itself, it can be synthesized, or it can be exogenous also. Okay, exogenous pigments means most common exogenous pigment is nothing but carbon. Okay, it is it is coming from outside the body. Gold dust, yeah, ubiquitous air pollutant. In case of urban areas, ubiquitous air pollutant is nothing but carbon. Okay, when inhaled, macrophages usually pick up the carbon in the urban areas. Within the alveoli, it is transported usually through lymphatic channels. Okay, to the regional lymph nodes. For example, in tracheobronchial region, we have deep cervical lymph nodes, and we have those kind of lymph nodes. So the macrophages, it will be picking up the carbon through alveoli. It will be transported through lymphatic channels to the regional lymph nodes. Okay, accumulation of this pigment usually it will be blackening the tissue. So if there is blackening of the tissues of the lungs due to the accumulation of this carbon pigment, we'll say it as anthracosis. And not only the blackening of tissue of the lungs, but also involved in lymph nodes, intercostal lymph nodes, they know. So blackening of lymph nodes happens in coal miners. Okay, the aggregates of carbon dust may induce a fibroblastic reaction. So those carbon dust, it will when in case of coal miners, it will be inducing a fibroblastic reaction. Those fibroblasts, it will undergo a reaction, or even emphysema. It is caused because of the aggregates of carbon dioxide, and thus causes serious lung disease. And that disease will be denoting as coal workers pneumoconiasis. Coal workers pneumoconiasis is caused only because of the fibroblastic reaction, or emphysema. It is caused because of the aggregation of the carbon dust. Okay, coal workers pneumoconiasis is caused. First one is anthracosis, because of the blackening of the tissues of the lungs, and second one is coal workers pneumoconiosis. So this is second one. Third one is tattooing. It is a form of localized exogenous pigmentation of the skin. This is exogenous. This is also exogenous. Anthracosis, pneumoconiosis, and pneumoconiosis, and tattooing. Tattooing is nothing but we know pigments actually inactivated or phagocytized by dermal macrophages. Okay, dermal macrophages, which is found under the skin, it will be phagocytizing those pigments. Okay, in which they reside for the remainder of the life. Okay, actually it will be residing for the whole of the life. The pigments do not usually evoke any. Actually, these pigments will be not evoking any inflammatory response. So there are three types of exogenous pigments. So three types of no three. There are three conditions in which exogenous pigments cause injury. They are nothing but anthracosis, tattooing, and coal workers pneumoconiosis. But tattooing is not so it's not a one which induces inflammatory response, but coal workers pneumoconiosis and anthracosis are dangerous. Let's go to endogenous pigments. Lipofuscin is an insoluble pigment. We have lipofuscin, which is an insoluble pigment, which is not soluble, also known as lipochrome. Those insoluble pigment will be denoting as lipochrome or wear and tear pigment. Lipofuscin, it is composed of polymer of lipids and phospholipids. Okay, if lipids and phospholipids, if it is combined with protein, lipids and phospholipids, and if it is combined with protein, we will say it as lipofuscin. This is very important question. Lipofuscin is nothing but if lipids and phospholipids, if it is getting combined with protein, we will be saying it as Those insoluble pigment is lipochrome or wear and tear pigment. If lipids and phospholipids get complex with proteins, suggesting that it is derived through. Why? Because it is derived from lipid peroxidation of polyunsaturated lipids of subcellular membranes. We have subcellular membranes, under that we have polyunsaturated lipids. Because of the lipid peroxidation of the polyunsaturated lipids of the subcellular membranes, those lipids and phospholipids get combined with proteins. So this forms lipofuscin. Lipofuscin is not actually, it is not injurious to cell or its functions. Okay, that you have to know. So though it is due to lipid peroxidation of polyunsaturated lipids of subcellular membrane, it is not injurious to cell or its functions. Its importance lies in its being a telltale sign of free radical injury. It is a telltale sign of free radical injury and lipid peroxidation. It is a telltale sign of free radical injury and lipid peroxidation. The term is derived from Latin fuscus brown. Okay, actually the term it is derived from Latin. We say fuscus brown. Fusin means fuscus brown, referring to a brown lipid. Fuscus brown is nothing but it will be referring brown lipid. In tissue sections, it appears as yellow brown. How it appears? It appears as yellow brown. Usually we'll be referring it as brown lipid. In tissue sections, it appears as yellow brown. Finely granular cytoplasmic, often perinuclear pigment. Finally, it is granular and it is cytoplasmic. Often it is perinuclear, is nothing but at the eccentrically the nucleus is flattened. Perinuclear pigment. So the term it is derived from fuscus brown, referring it as brown lipid. It appears as yellow brown and it is finely granular cytoplasmic and often perinuclear pigment. Okay. It is seen in cells that is undergoing slow regressive change. You have certain cells and those cells undergo slow regressive changes, and is particularly it will be there in liver and heart of aging patients. In case of aging patients, their liver and heart they undergo slow and regressive changes. In those people you will be seeing this perinuclear pigment, which is yellow to brown color and finely granular and cytoplasmic. Okay, or patients with severe malnutrition. So some patients they will be suffering from severe malnutrition and they may also have undergone cancer cachexia. So some of the patients who have undergone severe malnutrition and cancer cachexia, so in those patients, especially in the liver and heart of aging patient, liver and heart, we'll be seeing perinuclear pigment or finely granular cytoplasmic pigment. Okay. Cancer cachexia, we'll be seeing lipofuscin, perinuclear pigment, liver and heart of aging patients. Okay, melanin, it is generally now let's go to melanin. We have seen lipofuscin. We have known in which type of people usually it comes to the aging people with severe malnutrition, cancer, cachexia, liver and heart of aging patients. Okay, let's move to melanin. Melanin it is derived from Greek. It is endogenous brown black pigment. We know it is a brown and black pigment formed in the enzyme tyrosinase. So oxidation of tyrosine to dihydroxyphenylalanine happens in melanocytes. Oxidation of tyrosine to dihydroxyphenylalanine happens in melanocytes, for which the enzyme tyrosinase is used. Okay. So in that process, in that oxidation, this brown black pigment is produced, and that is called melanin. It for practical purposes, melanin it is only endogenous brown black pigment. Okay, the only other that could be considered in this category is homogentic acid. Okay, endogenous pigment, which is brown black pigment. Okay, so another black pigment is nothing but homogentic acid. It will be occurring in patients only with alkaptonuria. Alkaptonuria is nothing but where alkapton bodies come because of the defect in the enzyme called homogentic acid. Okay, so it is a rare metabolic disease. Here the pigment is deposited in the skin. In case of alkaptonuria, the pigment is deposited in the skin, connective tissue, and not only connective tissue but also cartilage. And the pigmentation is known as ochronosis. Ochronosis, the pigmentation of these black kind of bodies in the skin, connective tissue, cartilage is called ochronosis in case of alkaptonuria. And not only this, but also because of the tyrosinase, because of the defect in tyrosinase enzyme, There may be also lack of melanin, but don't go over that. Melanin is a brown black pigment. Okay, no, up to that. Okay, first one is lipofilling that we have seen. Next one is melanin. Okay, next one is ochronosis, that is nothing black due to the black pigment of homogenetic acid. Next, let's see about hemosiderin. It is a hemoglobin derived golden yellow to brown. The same thing. There yellow to brown for lipofilling. Here golden yellow to brown for hemosiderin. It is a granular or crystalline pigment. Granular or crystalline pigment. There it is only find the granular cytoplasmic lipofuscin. Here it is granular or crystalline pigment. It is one of the major storage forms of iron. Okay, iron metabolism and hemosiderin. Hemosiderin is involved in iron metabolism. Iron is normally carried by specific transport protein. The specific transporter is transferrin for iron. In cells, it is stored in association. Usually, iron is stored in cells with the protein. Okay, so the storage form of iron with a protein is apoferritin. And together it will be forming ferritin miscellaris. With protein, if the ferritin it is stored, we'll say it is apoferritin, and together it forms ferritin miscellaris. Ferritin is a constituent of most cell types. Yes, of course, protein. Okay, it is stored and associated with protein, so it's apoferritin, and together it forms ferritin miscellaris. Ferritin is a constituent of most cell types. When there is a local or systemic excess of iron, ferritin will be forming hemosiderin granules. Hemosiderin is nothing but storage forms. So if there is local or excess form of iron, if that apoferritin, which is stored in the form of protein plus iron, and together it forms ferritin miscellaris. If it gets accumulated more, than it forms hemosiderin granules, which are easily seen with a light microscope. We know we have light microscope. Through light microscope, those hemosiderin granules are easily seen. Hemosiderin pigment represents aggregation. So we have hemosiderin pigment. It will be representing the aggregation of what? Ferritin miscellaris. Okay. Under normal conditions, small amounts of hemosiderin can be seen in the mononuclear phagocytes of the normal conditions. In case of mononuclear phagocytes, especially in bone marrow, spleen, liver, we'll be seeing small amounts of hemosiderin. It will be actively engaged in red cell breakdown. Bone marrow, spleen, anything but the sites which are involved for red cell breakdown, those small amounts of hemosiderin through which ferritin miscellaris are accumulated under normal conditions, they can be seen in mononuclear phagocytes of bone marrow, spleen, liver. Okay, which will be engaged in red cell breakdown. If there is local or systemic excess of iron, it will be causing the hemosiderin to accumulate within the cells. Local or systemic excess of iron, it will be causing hemosiderin to accumulate within the cells. Okay. Local excess result from hemorrhages. Why that occurs local excess? Because maybe due to hemorrhage in tissues. The best example of localized hemosiderosis is the common BRIOS. Localized hemosiderosis best example is common BRIOS. Extravasated red cells at the site of injury are phagocytosed. Those red cells at the site of injury, it is phagocytosed over several days by macrophages. Macrophage is nothing but the destroyer of RBC, extravasated red cells at the site of injury. So when this is phagocytosed, it will be breaking down the hemoglobin and recover the iron. So now iron is recovered at the site of injury by the phagocytosis by macrophages. After the removal of iron, the hemoiety, it is converted first to biliverdin and then to bilirubin. Fe, iron to biliverdin to the bilirubin. In parallel, the iron released from heme is incorporated into ferritin, eventually hemosiderin. Okay. In parallel, we have iron. It will be released from heme and incorporated into ferritin. Not only be converted into biliverdin, bilirubin, but also it will be released from heme. It will be incorporated ferritin. Eventually, is a ferritin, apoferritin, ferritin miscellaris, and hemosiderin. These conversions account for the often dramatic play of colors seen in a healing bruise. So you have a wound. So when you are wounded, especially, there occurs typical color changes first from red to blue. RB, just remember RB. Next to GB. RB is red to blue. Next to GB. Next remember Goa, just like Goa, remember golden yellow. Before it is RB, GB, red to blue, green, blue, golden yellow. RB, GB, golden blue. How? Because of the local excess, because hemorrhages in tissue, chemosiderin get accumulated. How chemosiderin? Because of the extravasted red cells at the site of injury to be phagocytous by macrophages, hemoglobin. If it is recovered from the hemoglobin, it will be converted into apoferritin, apoferritin to ferritin mesylase, ferritin mesylase to chemosiderin, where it gets excess. In case of injury, and some of the iron it will be converted to biliverdin, bilirubin also, from the green bile to red bile. And keeling briefs, the typical color changes RB, GB, GO, red, blue, cream blue, golden yellow before it is resolved. When this is due to local or systemic excess. When there is systemic overload of iron, this is local excess. When there is systemic overload of iron, hemocysteine may be deposited in case of many organs and tissues. So if hemocysteine, if it is deposited in many organs and tissues, such conditions where hemocysteine, if it is accumulated in many organs and tissues, called hemosiderosis. The main cause of hemosiderosis are increased absorption of dietary iron due to an inborn error of metabolism. So if there is inborn error of metabolism, we'll be saying as hemochromatosis. So if there is inborn error of iron metabolism, such metabolism is hemochromatosis, due to which in dietary iron it is increasingly absorbed. So that condition is hemosiderosis. Hemolytic anemias, in which premature lysis of red cells lead to release of abnormal quantities of iron. Premature lysis of red cells. So hemolytic anemias and hemochromatosis, which is an inborn error of metabolism. Repeated blood transfusions, because transfused red cells constitute an exogenous load of iron. So systemic overload of iron is due to increased absorption of dietary and hemochromatosis, hemolytic anemias, repeated blood transfusion. So these are the reasons for systemic overload of iron. So now we have seen endogenous pigments, and that we have seen lipofusin, lipochrome, we have seen melanin, we have seen alkapton bodies, ochronosis, we have seen hemosiderin, and we have seen mononuclear phagocytes, small amounts of mononuclear phagocytes engage in red cell breakdown, and we have seen local excess and systemic excess. We have in exogenous pigments, we have seen tartine, coal, pneumoconitis, and anthracosis. In glycogen, in glycogen, we have seen glycogen storage disorders and glycogenesis, and best cabin and pass reaction, out of which rose to violet and palak hydrolyzation. In hyaline change, we have seen intracellular hyaline, extracellular hyaline in long-standing hypertension, diabetes mellitus, and we have seen biochemical basis. We have seen the hyalinization of collagenous fibrous tissue. In intracellular hyaline change, the examples are nothing but reabsorption, droplets, and proximal renal tubules, defective intracellular transport, accumulation of cytoskeletal proteins, aggregation of abnormal proteins. Amyloidosis, we have seen abnormal proteins, accumulation of cytoskeletal proteins because of keratin, because of neurofibrating Alzheimer's disease, defective intracellular transfer secretion of critical proteins, alpha-1 antitrypsin deficiency, partially folded intermediates we have seen, and result bodies, endoplasmic reticulum becomes hugely distended, normal secreted proteins, excessive amounts, reabsorption droplets in proximal renal tubules. We in cholesterol and cholesterolysis we have seen axon, atherosclerosis, xanthomas, cholesterolosis, Niemann-Pick disease. Okay, axon, cholesterol and also in macrophages, cholesterol gets accumulated in case of intima. Cholesterolosis, lamina propria of gallbladder. Niemann-Pick disease, cholesterol trafficking enzyme. Steatosis, heart, term steatosis, nothing but because of including toxins, protein malnutrition, diabetes mellitus, obesity, and anoxia, and all those we have seen. And what are the 4 reasons which are responsible for intracellular accumulations? Maybe inadequate removal of normal substance, accumulation of abnormal endogenous substance may be due to genetic or acquired effects, deposition accumulation of abnormal exogenous substance, nor its neither the enzymatic machinery to degrade or nor the ability to transport to other sites, failure to degrade, and maybe due to failure to degrade a metabolite because of inherited enzyme deficiency. This intracellular accumulations. This is a lecture on intracellular accumulations. It will be very helpful if you integrate with Robbins.